Stage 2 of the upper to lower lid tarso-conjunctival flap or Hughes flap procedure involves division of the flap. Traditionally, this used to be done about 6 weeks after stage 1, but in fact the flap can be divided as early as a week after the primary surgery. A 4/0 silk traction suture is inserted into the upper lid grey line. When the flap is fashioned, the upper lid retractors are pulled inferiorly, which is similar to the plication that is done in posterior approach ptosis surgery. Therefore, in stage 2, it is advisable to release the retractors to minimize the risk of postoperative lid retraction. The plane between the retractors and the conjunctiva must be identified. Usually a few small snips with spring scissors are required to find the plane, as you see here. The plane can then be continued superiorly relatively easily with blunt dissection. There is no specific superior limit of dissection. It just has to be far enough to allow the retractors to return to their normal location. However, the white line on the posterior surface of the folded levator, which probably represents the point at which the muscle becomes aponeurosis, is a good target. The flap is now divided. Some people advocate dividing it with the skin slightly recessed in order to reduce the likelihood of skin overgrowth onto the lid margin. Conversely, others recommend dividing the flap with the skin edge slightly advanced, as this may reduce the likelihood of the thickened red lid margin that can occur in the first few months after a Hughes flap. In view of this disparity of opinions, we tend to cut the flap horizontally, or with a very slight skin recession, as you see here.